Prometric Q&A. Rationals. Basic care and comfort. 1. As the registered nurse in the emergency department, you are taking care of an adolescent client who had just fractured their femur during gymnasium class at their high school. After casting, you will be discharging the client with crutches. Which of the following client goals that is paired with its learning domain should be included in the patient teaching plan for this client and the parents? Psychomotor domain, the client will slightly bend their elbows when holding the hand grips. Psychomotor domain, the client will rest their weight on the padded areas on the top of the crutches. Cognitive domain, the client will slightly bend their elbows when holding the hand grips. Cognitive domain, the nurse will tell the client how often the tips on the crutches must be replaced. Answer: A. The client goal that is paired with its learning domain that should be included in the patient teaching plan for this client and the parents is the client will slightly bend their elbows when holding the hand grips, which is part of the psychomotor domain and not the cognitive domain. Lastly, the nurse will is an intervention and not a client goal or expected outcome, which should be learner, not nurse, oriented. 2. Which basic activity of daily living assistive device can be useful for the client who is affected with poor fine motor coordination? An aphasia aid. A button hook. Honey thickened liquids. A word board. Answer: B. The basic activity of daily living assistive device can be useful for the client who is affected with poor fine motor coordination is a button hook that would be used for the dressing activity of daily living. An aphasia aid and a word board are assistive devices to facilitate communication when the client is affected with a communication deficit such as aphasia. Honey thickened liquids are indicated for clients with a swallowing disorder and they are not indicated for clients with poor fine motor coordination. 3. As the nurse in an ambulatory care area, you see a new client enter with a cane that appears too short for the client. What should you do? Place the client in a wheelchair to protect their safety in the clinic. Remove the cane from the client to protect their safety. Teach the client about the proper length of a cane. Have the client use a wheelchair rather than the cane. Answer: C. You should teach the client about the proper length of a cane. The proper length of the cane should be the length that only permits the client's elbow to be slightly flexed. Some canes like a wooden cane are not adjustable to the client's height and others can be adjusted to meet the height needs of the client. You would not place the client in a wheelchair or ask the client to use a wheelchair, and you would also not take the cane, which is their personal property, away from them. You would use this observation as a learning need assessment and, as such, you should teach the client about the proper length of a cane and help them to adjust the height of the cane if the client's cane is a height adjustable one. 4. You are caring for a post-operative client who is complaining of abdominal distention and flatus. Which intervention would you most likely do for this client? A cleansing enema. A retention enema. A return flow enema. A laxative. Answer: C. The most likely intervention for this client, after getting a doctor's order, is a return flow enema. Return flow enemas, similar to a carminative enema, are used to relieve flatus and stimulate peristalsis, which is frequently a problem after a client has received anesthesia. Cleansing enemas are used to relieve constipation, and a retention enema is used to administer medication, to soften stool and to lubricate the rectum so that it is easier and more comfortable for the client to defecate. The data in this question does not indicate that the client is constipated and in need of a laxative. 5. Which of the following is a commonality that is shared in terms of both restraints and urinary catheters? Both can lead to infection. Both are invasive procedures. Both are considered sentinel. Both are the last resort. Answer: D. The commonality that is shared in terms of both restraints and urinary catheters is that both are the last, not the first, treatment of choice. Both indwelling urinary catheters and restraints pose risks and complication, therefore, both of these interventions must be prevented with the use of preventive measures. Indwelling urinary catheters are invasive but restraints are not invasive. Indwelling urinary catheters can lead to infection but restraints do not. Neither are sentinel. A sentinel event is an event or occurrence, incident or accident that has led to or may have possibly led to client harm. Even near misses that have the potential for harm are considered sentinel events because they have the potential to cause harm in the future. 6. Your incontinent client is incontinent of urine and stool. Which of the following products would you recommend for this client when cost is a major consideration in this decision? Any solid skin barrier. A hydrocolloid solid skin barrier. Hollister's Flex Tend. A skin sealant. Answer, D. You would recommend a skin sealant, including products like Bard's Protective Barrier and Combatec Softcare, which are a fast-drying polymer transparent film that can be applied relatively simply with a wipe or a spray. These products are easy to use and less expensive than solid skin barriers, including Hollister's Flex Tend and others containing hydrocolloids. 7. You are planning discharge education for your client who has a new colostomy. Which complication of a colostomy should you educate this client about? A prolapsed stoma. A vitamin B12 deficiency. Nocturnal enuresis. GI stone formation. Answer, A. Some of the complications associated with a colostomy include a prolapsed stoma, infection, dehiscence, and ischemic ileostomy, a peristomal hernia, stoma stenosis, stomal retraction, necrosis, mucocutaneous separation, stomal trauma, peristomal skin damage as the result of leakage, and peristomal hernias. A vitamin B12 deficiency, nocturnal enuresis, and urinary stone formations are complications associated with urinary diversion and not fecal ostomy diversions. 8. Select the hazard of immobility that is accurately paired with an appropriate expected outcome of care that the nurse provides to prevent this complication. Bone demineralization, turning and positioning every 2 hours. Urinary stasis, the client will consume 1,000 milliliters of oral fluids per day. Muscle atrophy, the client will perform range of motion exercises at least 3 times a day. Hypercalcemia, maintaining fluid intake of 1,000 milliliters per day. Answer, C. The client will perform range of motion exercises at least 3 times a day is an appropriate expected outcome of care that the nurse provides to prevent this complication. Urinary stasis and hypercalcemia, both hazards of immobility, can be prevented when the client will consume 2,000 milliliters of oral fluids per day. Lastly, calcium loss from the bones can be prevented by weight-bearing activity, and not turning and positioning in bed. 9. During your musculoskeletal assessment of the client, you determined that the client has muscular strength against gravity but not against resistance. You would document this assessment as 1 on the scale of 1 to 3, 2 on the scale of 1 to 5, 3 on the scale of 0 to 5, 4 on the scale of 0 to 5. Answer, C. You would document this client's muscular strength as a 3 on a scale of 0 to 5. Muscular strength is classified on a scale of 0 to 5. 0. No muscular contraction. 1. No muscular movement, only a quiver is noted. 2. Muscular movement, but only when assisted with gravity. 3. Muscular movement against gravity, but not against resistance. 4. Muscular movement against resistance. 5. Full muscular movement and strength. 10. You are working as a wound care nurse. You measure the size of a client's wound and it is 3 centimeters deep, 2 centimeters long, and 4 centimeters wide. You would document the dimension of this wound as 6 centimeters, 12 centimeters, 20 centimeters, 24 centimeters. Answer, D. You would document the size of this wound as 24 centimeters. After the wound is assessed and measured, the wound dimension is calculated by multiplying the length by the width by the depth of the wound. For example, when the length of the sound is 3 centimeters deep, 2 cm long and 4 cm wide, it is calculated with 3 times 2 times 4 is equal to 24 cm. 11. Your client had a ruptured appendix and peritonitis. What type of healing would be most likely for this client? Secondary intention healing, tertiary intention healing, primary prevention healing, secondary prevention healing. Answer: A. Secondary intention healing is the most likely type of wound healing for this client because of the risks associated with the deep infection associated with the ruptured appendix and the peritonitis. Secondary intention healing, also referred to as healing by second intention, is done for contaminated wounds in order to prevent infections, to prevent the formation of abscesses, and to promote healing from the bottom up to the outer surface of the skin so that any potential infection is not closed in at the bottom of the wound. These open wounds are irrigated with a sterile solution and then packed to keep them open and, over time, they will heal on their own. The resulting scar is more obvious than those scars that result from primary intention healing. Primary intention healing is facilitated with wounds without infection. The wound edges are approximated and closed with a closure technique such as suturing, steri strips, and surgical glues. Tertiary intention healing, also referred to as healing by tertiary intention, is a combination of secondary and primary healing. Tertiary intention healing begins with several days of open wound irrigations and packing, which is secondary healing, followed by the closure of the wound edges with approximation and suturing, which is primary healing. Some traumatic wounds are healed with tertiary intention. Primary, secondary and tertiary prevention strategies are prevention, interventions and restorative or rehabilitation care and not methods of wound healing. 12. You are caring for a client whose pressure ulcer is yellow. Which treatment will you most likely employ for this wound? A barrier film, an alginate dressing, surgical laser debridement, autolytic debridement. Answer: B. The treatment of pressure ulcers is complex and it often includes a combination of treatments and therapies. The RYB color code of wounds is sometimes used by nurses to guide the treatment options. RYB stands for the colors of red, yellow and black. The rules of treatment for these three colors are: red, covering with a dressing such as a hydrocolloid film, turning and positioning the client and avoiding pressure, friction and shearing. Yellow, using an alginate dressing. Black, debridement, including surgical laser debridement, mechanical debridement, autolytic debridement, enzymatic debridement and sharp instrument debridement of the area to remove the black necrotic eschar. 13. Which of the following theories of pain are you utilizing when you recognize the fact that some of the factors that open this gate to pain are low endorphins and anxiety, and that some of the factors that close this gate to pain are decreased anxiety and fear? Moritz Schiff's theory of pain. The intensive theory of pain. Melzack and Wall's theory of pain. The specificity theory of pain. Answer: C. Melzack and Wall's gate control theory of pain supports the belief that some of the factors that open this gate to pain are low endorphins and anxiety, and that some of the factors that close this gate to pain are decreased anxiety and fear. The substantia gelatinosa is the gate that facilitates or blocks the transmission of pain. The specificity theory of Moritz Schiff described pain as a sensation that was different from all the other senses in that pain had its own specific nervous system pathways from the spinal cord that traveled to the brain. The intensive theory of pain is based on the belief that pain is an emotional state, rather than a sensory phenomenon. The peripheral pattern theory of pain of Sinclair and Weddell describes pain as the result of an intense stimulus applied to the skin, and the neurometrics theory of pain supports the fact that pain is a dynamic and multidimensional process with physical, behavioral, perceptual, psychological and social responses, and one that can only be described by the person who is experiencing it. 14. You routinely use the PQRST method to assess pain. The PQRST method consists of pain level, the quality of the pain, the region or area of the pain, the severity of the pain, and the pain triggers. Precipitating factors, the quality of the pain, relief factors, the severity of the pain, and the pain triggers. Pain level, the quantitative numerical pain score, the region or area of the pain, the severity of the pain, and the pain triggers. Precipitating factors, the quality of the pain, the region or area of the pain, the severity of the pain, and the pain triggers. Answer, D. Precipitating factors, the quality of the pain, the region or area of the pain, the severity of the pain, and the pain triggers are the PQRSTs of the PQRST method of pain assessment. The severity of the pain, which can include a quantitative, numerical pain score from 1 to 10, for example, is the S of the PQRST method of pain assessment. 15. The A, B, C, and DS of a complete and comprehensive nutritional assessment includes assessment data, biochemical data, clinical data and dietary data. Ancestral cultural data, biochemical data, clinical data and dietary data. Anthropometric data, biological data, chemical data and dietary data. Anthropometric data, biochemical data, clinical data and dietary data. Answer, D. Anthropometric data, biochemical data, clinical data and dietary data are the A, B, C and DS of a complete and comprehensive nutritional assessment. The elements of these A, B, C and DS of nutritional assessment include A. Anthropometric data. This data includes variables such as height, weight, body mass index and arm measurements such as the mid-arm circumference and the tricep skin fold. B. Biochemical data, laboratory testing data like serum albumin, hemoglobin, urinary creatinine, and serum transferrin. C. Clinical data, the client's skin condition, level of activity and status of the client's mucous membranes. D. Dietary data. This data includes the client's subjective reports of their food and fluid intake over the last 24 hours and the types of foods that are typically eating. 16. Your client has a tube feeding. Which of the following commonly occurring complications of tube feedings can you prevent with the preventive measure that is coupled with it? Constipation, the provision of a high-fiber diet. Urinary pH changes, encouraging ample oral fluid intake. Aspiration, maintaining the client in at least a 30-degree angle. Aspiration, maintaining the client in at least a 90-degree angle. Answer, C. Aspiration can be prevented by maintaining the client in at least a 30-degree angle. A 90-degree angle is not only not necessary, this angle places a client at greater risk for the development of a pressure ulcer. Diarrhea, rather than constipation, is a complication of tube feedings, and urinary pH changes are not a commonly occurring complication of tube feedings. Some of the other complications and preventive measures are diarrhea, maintaining a slow rate of infusion whenever possible, changing the ordered rate and formula when necessary. Abdominal pain, maintaining a slow rate of infusion whenever possible. Dehydration, monitor the client for any signs and symptoms of dehydration, measure intake and output and notify the doctor of any abnormalities. Nausea and vomiting, slowing the rate down, changing the formula and antiemetic medications to stop the vomiting and to prevent any aspiration. Tube dislodgement, secure and monitor the tube. 17. Which of the following impacts on the client's preferences in terms of hygiene routines and practices? Culture. Locus of control. Bodily surface area. Diaphoresis. Answer, A. There are a wide variety of different factors that influence and impact on our clients' hygiene habits and routines. For example, cultural practices and beliefs, ethnical factors, religious practices and beliefs, the client's level of growth and development. Although the locus of control, bodily surface area and diaphoresis, in addition to other factors such as economic constraints, the client's level of energy, the client's level of cognition, and environmental factors can impact on hygiene, these are not factors that impact on the client's hygiene and hygiene practices. They do not typically impact on the lifelong developed hygiene and hygiene practices. 18. Select the age group that is accurately paired with the normal and recommended hours of sleep each day. The neonate, 10 to 15 hours a day. The toddler, 11 to 14 hours a day. The preschool child, 12 to 15 hours a day. The school-age child, less than 8 hours a day. Answer, B. The age group that is accurately paired with the normal and recommended hours of sleep each day is the toddler should sleep about 11 to 14 hours per day. The neonate should sleep 14 to 17 hours per day, the preschool child should sleep 10 to 13 hours per day, and the school-age child should sleep 9 to 11 hours per day.